Subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. My topic is first trimester ultrasound. First of all, I thank Academy of Family Physicians to invite me for this lecture, and this will be only in the third trimester which we are going to discuss. Dating of pregnancy. Clinical assessment is not good. Sonographic evaluation is better because clinical assessment may be wrong because of faulty memory, irregular cycle, spotting during pregnancy, and large uterus due to uterine or ovarian masses. Like in this case, it's a 7-week, 5 days pregnancy with a large ovarian cyst. So this may appear as a 5-month pregnancy, which is wrong. The early pregnancy, before we start that one, there are some problems which may happen and prevent pregnancy. This is a endometrial polyp, and it shows blood supply hysterosonogram. And this is a single layer endometrium. As Professor Safdar Malik has told, that this is a bad endometrium for reception and implantation of the ovum. This is a better triple layer endometrium because this has a 67% chance of implantation and normal pregnancy, whereas single layer has a 35% chance of normal pregnancy. Now, first change you will see when the pregnancy starts is the decidual reaction. The endometrium starts growing and becomes thick, like in this case. And then about 5 weeks, you can see the gaseous sac. This is how it happens. Ovulation, fertilization, then goes in here and embeds in one layer of the endometrium. The endometrial cavity will be left in the middle. So first thing is the gaseous sac. In this case, you have to take 3 measurements: transverse, longitudinal, and AP diameter, and you add them up and divide by 3. This gives you the mean sac diameter, which is very important, mean sac diameter. And also you should see a double decidual sign. This is the implanted ovum, this is the endometrial cavity, and this is the other wall of the endometrium. In this case, you can see the gaseous sac as well as IUCD in the lower uterine segment. So once IUCD has been placed, you should check for its position, otherwise it will not prevent pregnancy. And pseudogaseous sac, it will have a single wall, it will not have a double wall. This is one layer here, and this fluid in the endometrial cavity. Now yolk sac. This is a fish embryo, and you can see the yolk sac, and here you can see another yolk sac. So we are going to see the yolk sac in the early pregnancy. And the first structure to appear, first is the decidual reaction, then is the gaseous sac, and then the yolk sac. It has a role in the transfer of nutrition to the embryo in the 2nd and 3rd weeks, by the time the uteroplacental circulation is developing. So this has a role in nutrition. And after 12 weeks, you may not see it, but it is there. So it should not be more than 6 millimeters. More than 6 millimeters is abnormal, and the pregnancy may not progress accordingly. And you should be able to see the sac 12 millimeter and yolk sac on TVS should be visible. And if you don't see it, that means it's a failed pregnancy. More than 8 millimeter yolk sac, that is also abnormal. This will also have an abnormal pregnancy. Floating yolk sac containing debris, grossly misshapen, these are bad signs for pregnancy. This is the embryo, this is the amnion, amniotic membrane, this is the chorion. That's where it lies, at the junction of amnion and chorion. And here you can see the yolk sac, and you can see the embryo. And here you can see a calcified yolk sac. That's also a bad sign. The pregnancy is not going to progress normally. Blighted ovum. It is a fertilized egg that implants but does not develop. In a blighted ovum, a gestational sac forms and grows. The embryo does not develop. It is known as an embryonic pregnancy. A blighted ovum is a type of miscarriage. Embryo never develops or stops growing at a very early stage and disintegrates. It is believed that blighted ovum are the result of chromosomal abnormality. In 93, a study was done and they found 67% abnormalities of the chromosomes in the cases of blighted ovum. Beta HCG is done, and if it is higher, then you look at the gestational sac, and 8 millimeter without a yolk sac, it is a bad sign. And that's what happens. You can see a sac, but no yolk sac and no fetal pole. And here you can see a misshapen, and here you can see some subchorionic bleed. Missed abortion is 7 millimeter embryo, but no heartbeat. If you don't see a heartbeat, do the transvaginal sonography. And to avoid error, never ever commit that it is a missed abortion. Advise repeat ultrasonography in 7 to 10 days, so you don't make a mistake and patient has a DNC, whereas it may be a normal pregnancy. A missed abortion is a dead fetus in the uterus for some time, usually weeks to months. And here you can see it, 7 weeks, 4 days, pregnancy was advanced, and if you're not sure, use color Doppler to look for the cardiac activity. This is a CRL. Then you can have bleeding with subchorionic hemorrhage, this one here. Now some people, they ask that how the subchorionic or subplacental hematomas look like on color Doppler. It will show a grayscale structure because Doppler will give you only if it is a flowing blood, venous or arterial, but the clotted blood will not give you any Doppler shift. And here you can see subchorionic hemorrhage. And here you can see 8 weeks fetus with embryo, and you can see a small umbilical cord developing, and this is a flow in the subplacental area. RPOCs, usually after cesarean or after delivery, there is continuous bleeding and spotting, and they send the patient for retained products of conception. So the first thing you should see is an endometrial mass. It is the most sensitive finding of RPOC. If no mass or endometrial fluid is seen and the endometrium thickness is 10 millimeter, RPOCs are extremely unlikely. So there should be a mass or there should be fluid in the endometrial cavity, and if it is 10 millimeter or less, then there is less chance of RPOC. Absence of blood flow does not exclude the diagnosis of RPOC. Actually, the blood flow we want to see is that if there are alive chorionic villi, that will give you the Doppler shift. But if the flow is slow, velocity is less, you may not see it. So this is not a diagnostic. If you see it, it's fine. If you don't see it, this does not rule out RPOC. That's how the RPOC look like. Echogenic mass in the endometrial cavity, like this one, and you may see some flow in there due to live chorionic villi. Abnormal location of pregnancy. Once the pregnancy starts, the ovulation starts, it can fertilize in the abdomen or in the ovary, fimbrial end, ampullary end, isthmus, interstitial, in the cervix, in the cesarean scar, like this one is a low implantation in the lower uterine segment. This is abnormal location of pregnancy that we should look for in the first trimester. In this case, it is implanted in the cervical canal. It's in the cervix. That we should be very conscious about it. This is retroverted uterus. This is the posterior wall, this is the anterior wall. This is the cesarean scar. So it has occurred in the scar. So this is the location to look for abnormal pregnancy and also look for the placenta accreta or increta, where the placenta grows inside the myometrium. And you can have heterotopic pregnancy inside the uterus and outside the uterus. That we have to look for. Then when you see an ectopic pregnancy, this is called ring of fire sign. It may not be present in 100% cases, maybe around some follicles or inflammation, but this is one of the signs of abnormal pregnancy. And here you can see gestational sac, fetal pole, and also you can see the ring of fire sign. Now, first thing which you can see is that patient comes in with pregnancy test positive and pain abdomen, and first thing you will see in ruptured ectopic is the free fluid in the pouch of Douglas. And if the fluid shows debris, that's a sure sign the patient is bleeding. Otherwise you can say there is a fluid/blood in the cul-de-sac. But if you see this echogenic fluid with debris, that's a sure sign that patient has a ruptured ectopic. And this is a ectopic with hematoma formation. Then molar pregnancy. If beta HCG is strongly positive and you don't see any fetal pole, look for these cystic areas in the uterine cavity, and this is a typical appearance of molar pregnancy. It will cause bleeding also, and it may show some vascularity in parts of this. You can have a partial mole where you will see the fetus, and fetus will be growing, but the placenta shows molar changes. Now we come to the CRL. Longest measurement of the embryo from the top of the head to the tip of the buttocks and excluding the limb buds. And it is accurate from 7 to 13 weeks. Gives a very accurate estimation of the gestational age. Dating CRL can be within 3 to 4 days of the LMP. So it's a very accurate method. An important point to note that when due date has been set by CRL, it should not be changed by subsequent scans. Once you set it, EDD, with CRL, with BPD, femur length, abdominal, and follow-up scans, you should not change the EDD if the dates are not sure. Most accurate measurement from 16 weeks onwards. We call embryo till 8 weeks and fetus after 8 weeks. That's how to measure it. You don't measure it along the curvature of the spine or on the occiput. It should be measured from the top of the head to the hips. And here you can see 7 weeks. These are the limb, but this should not be included. And FCA you should see by 6 to 7 weeks. And initially the heartbeat is 60 to 90 per minute. And then it increases to 130 to 160. Below 100 is bradycardia, and above 160 is tachycardia. And that's how you record this FCA if you want to give a documentary proof. Otherwise, you can just tell the patient FCA is present. And later on in pregnancy, you can do the AB ratio. Twins, you can see and look at this sign. If there's a thick triangular area here, that indicates it's a bichorionic and biamniotic. And if this area is not there and a thin membrane, then you should call it biamniotic. And if the membrane is not there, then it is monoamniotic, and you should look hard for conjoined twins. Thank you very much.